Well, my cat was off, wasn't it?
Just a little.
Hey, everybody. We are live. My count was a little bit off, so I have to apologize. I'm here with our guest. Welcome. We're going to give about 30 more seconds for people to sign on in before we get started. Thank you for those who are repeat customers, if you will. We'd love to have you back. As always, if you would like to share this webinar on social media with HawkTalk Live hashtag, you will be contacted, and we'd love to share a shirt with you and have you represent. We are also giving away a prize after every webinar, so stay please the entire time. We have some great clinical pearls for you from start to beginning or from start to finish. So glad to have you here. There you go. There's our little hashtag information if you missed my fast New England talking. Hashtag HawkTalk Live. I am here with Mike Voight. I'm going to stop this. There we go. Here's our pretty faces.
Hey, everybody.
Hey, howdy. I guess you would say howdy. I say aloha. You say howdy, right?
Yeah, we say howdy. Howdy, y'all. Howdy, you all.
Howdy, y'all. You got quite the southern draw. I wasn't expecting it when I first talked to you on the phone.
Yeah, a little bit of y'all on there.
So for those who don't know me, I'm Kate Miller. I am a physical therapist assistant. I have a couple degrees on that end. I'm also a fitness trainer and nutritional therapist. I work for HawkRips both as an instructor and as their education coordinator. I'm happy to lead these webinars. And today we have Mike Voight, who has quite the alphabet soup behind his name. I'll let him get into that in just a few minutes. But we're going to talk to you today about functional movement systems and kind of the growing importance thereof in the clinical rehab world. So, Mike,
I appreciate that, Kate. We'll try to get into talking about movement and things that I find passionate what I do in the laboratory for research. So I hope to provide a little bit of pearls on that and open the door for future discussion.
Well, I'm stoked. I've been to one of your courses before, and I think it's awesome information, honestly, to keep a part of, whether you're a DC, an OT, a PT, whatever rehabilitative field that you work in, AT rather. These things are vital to bring your patients back to life, because we too often focus on where the pain presents. And we've talked about this in several other webinars, rather than what is causing that pain, because pain is kind of a referred symptom a lot of the time.
Exactly right.
Mike, I'm going to hand it off to you. He has a great little slideshow for us.
We're going to do a little bit of slideshow first for the viewers that are watching. I'll take them through a short slide presentation. Then we'll come back to video and audio and take questions and see if we've opened some more discussion.
Great. And as usual, guys, if you're attending, if you're listening, please feel free to shoot out questions during the webinar. If I don't get to it right when you put the question up there, I promise I'll get to it before we wrap up.
Yeah, before we even go, I want to thank Kate for setting this up and invite me to be a part of this today. And certainly with HawkRips, with Frank and Sean in the home office, good friends, good people. And I've just gotten to know Kate over the last week and setting this up. And today, especially talking through what we're doing. So I do really appreciate you inviting me to be here today. And as you can sort of see from my title slide, I'm coming to you from Nashville, Tennessee. And I wear a lot of hats in Nashville. My primary job is in academia, and I teach at Belmont University in the School of Physical Therapy. I teach orthopedics and orthopedic assessment, as well as sports physical therapy. And I'm also at Vanderbilt University in the Department of Orthopedics, and I assist or hold a professorship there for the residency education. Having said that, I still have clinical practice and work at Nashville Hip Institute with Dr. Thomas Bird, and we see people out on the PGA Tour. So a lot of my clinical or sports practice now is working in golf and seeing golfers, although we see all kinds of people with hip injuries, and that will be a future topic down the road. And if that's not enough, just to keep us in the academic world doing things, the editor-in-chief of the International Journal of Sports PT, so constantly reading articles and doing things largely from my research interests in the lab dealing with movement issues or validating what we know about movement. And that was really what I wanted to talk about today, or go through today, is talking about the process of movement and where does that fit into the big picture with me and how I work with HawkRips and we do various things. And as some background information, I think this really sets the tone or sets the picture for what we're doing. And that's if you think about how most people were trained to evaluate, or how we look at things from an evaluation world, and it doesn't really matter, it's the traditional medical model typically, is that largely our assessment schemes were based on symptomatic treatment of inflamed tissue. In other words, people come in and they'll say to us, it hurts here, or this is where my chief complaint is. And we start to put our blinders on and become very myopic. And we look right at that point and start to evaluate this. So a person might come in with knee pain, or they might come in with various things. And the problem with that is, as instead of looking at the big picture, is that traditional medical model approach to assessment is making a huge assumption. And your assumption is that painful tissue is also the source of the problem. The best example, we could come up with several examples, but probably one of the best examples I could give you is this, is if we look at somebody's knee that comes in with knee pain, maybe a patellofemoral type problem, where's the problem? Well, we could all agree it's the knee, that's where it hurts, but where's the real pain? And where's the pain, where's the problem? Pain is at the knee, but problem is we're well aware in contemporary literature, it could be just as likely a hip problem, or for those that like to look at foot and ankle mechanics, certainly the foot and ankle contribute to this as well. So we tend to, as I said, our traditional way of thinking, put blinders on, and I kind of put it into two sort of categories, pathokinesiology versus pathoanatomical dysfunction. That traditional isolated approach, or as I just gave the example, looking at the knee, this pathoanatomical approach, to either your evaluation or your treatment's not going to restore the whole function. We've got to get rid of the mindset of chasing pain. Now, I'm not saying we ignore pain. I think you respect pain. I think we manage pain with our treatments, but we don't chase the pain. What we really need to do is try to get to the cause of the problem in the first place. Because if all we did was look at this pathoanatomical approach or do just isolated training, we can do real good, whether it's a strength training program or mobility. We can produce muscle development. We can pick a muscle and make it strong. But physical performance is about movement development. It's not about isolated joint function or isolated strengthening of a bad joint. So if you train the muscle, you ultimately may not completely develop the movement pattern that you're trying to restore. But if you train a movement pattern, the muscles, by nature of what we do, is going to get stronger or will develop appropriately. So we need to look closer at movement. Now, having said that, that kind of changes the paradigm. And if you think about our paradigm of treatment where most of us were trained, we would focus a lot of what we did at corrective exercise to a faulty anatomical part. Or we'd look at isolated joint function. But the reality of it is, today, we need to focus our treatment and or our corrective exercises at faulty movement patterns while considering the integrity of that anatomical part. Now, where I want to do is go a little bit of background here and shift gears a little bit, but I think this is important for all of us on the webinar today. Talking about this is because within the field now, specifically physical therapy, many of you may be aware of the Movement System Task Force that was developed or put together a few years ago, and I'm a member of this task force. And within the field of physical therapy, what was happening going back 5 or 6 years ago, the association did a study, and they studied external stakeholders to the field of physical therapy or rehabilitation. And what they said was the question that was asked to external stakeholders, so that could be patients, physicians, surgeons, other people, is what is it that a physical therapist does? Define physical therapy. And people were a little bit shocked in their answers because the answers that came back, and this was thousands of people, but the answers that came back were largely tools at which we used. In other words, people said, well, a physical therapist uses modalities, or a physical therapist uses ultrasound, or it could have been something simple as physical therapists use stretching exercises. They make me walk in parallel bars. Everything that put together, you could summarize it. It was a tool at which you use, but it didn't define you. Now, as an analogy, if I said to the group today, what is it that a cardiologist does? Not one of you on the webinar would think, well, they use stethoscopes and blood pressure cuffs. That's what a cardiologist does. No, we deal with the cardiovascular system. What's a neurologist do? The first thing in your mind wouldn't be they have reflex hammers in their pocket. You'd say they deal with the nervous system, and they deal with injuries with that. Orthopedists, for that matter. They deal with musculoskeletal. So APTA created a new vision for the profession, and it's a little bit elaborate on the slide here, but the new vision, for those that have not looked at it, but it's on the homepage for APTA, but is that the vision for the profession is that we transform society by optimizing movement to improve the human experience. Or the 5-second definition. What is it that a physical therapist does? Or what are they? The quick version is they're experts in human movement. Now, having said that, sort of follows from the website, the profession doesn't just seek to fix people or use isolated approaches to things, but rather we want to optimize movement to help maintain optimal movement and help people understand this. So again, the little 5-second version is we are experts in human movement or experts in movement. Now, jumping ahead a little bit with this, if that's important to us, then the question would be, how do we assess movement? And that's currently what the task force is wrestling with now. Is there a generic screen or assessment, rather, that we can do that everybody should get as a part of assessments? And at first, when you look at it, you think this is very, very difficult to do. It's almost overwhelming if you really started to think about it, to look at total body movement, how you do things. But the reality of it is, it's not all that hard. And in fact, for me, I have a system that I use, and people come to me, and I'm not trying to change the paradigm of evaluation. I still do observation and history and observations. I still do an upper and lower quarter screen. And at that point, I do a quick movement system assessment. And then from there, I go into my traditional rehabilitation programs. But the whole big picture, I think that's important today, maybe to grasp, that sort of sets a tone for the future, is the two guiding concepts of why I use a movement system approach to what I do. And that would be regional interdependence is one, and the stability and mobility model. And when I say regional interdependence, basically it's I could say a pretty fancy way in the literature now that describes what regional interdependence is. And that would be a concept that seemingly unrelated impairments in a remote anatomical region may contribute to or be associated with the patient's primary complaint. An easier way to think of it, and every one of you on this webinar learned it this way, is we always want to examine joints above and below the patient's primary complaint. And I'll say this one more time. There's two ways you could look at this, source and cause. To me, source is the tissue or that anatomical structure that's where the pain is emanating from, where they complain of pain, where they point to where their pain is. But what's most important to me is why do they have pain? The cause. What are the mechanical or movement impairments that causes the tissue irritation in the first place? Because if we focus on source and not looking at cause, the problem will always be there. On the other side, if we figure out what the exact cause is, the pain will go away. We'll get rid of the source. So we need to look for cause and not just the source. Now, again, just so we're clear, I'm not saying we ignore pain. We respect it and we manage it, but I don't chase it in my overall scheme. So the point of this regional interdependence and why this is so important to us is that when challenged, if you think about it, the human body will always find a way to move. The human body will always sacrifice quality over quantity of movement. So as an example, if you look at, if somebody on the call today, or all of us, if we thought about it, we had perhaps a total knee replacement yesterday, and they show up in the clinic today, you have a pretty good idea what they're going to look like. But if I said, okay, the person's sitting in my clinic and the fire alarm goes off, and they have to get outside my building, every person that would be in that clinic, or every one of you on this webinar today, would find a way to get outside of the building. But it wouldn't probably look pretty. You'd all have some crazy ways to move, I'm sure, but you'd find a way to move. And that's what I mean by the body will sacrifice quality over quantity. Now, there's a couple exceptions to this, and one exception would be if somebody had some sort of a disease like ankylosing spondylitis or something where all of our joints fuse. But outside of that, the body will find a way to move. And that's one of the tenets of what I look for in our overall approach to the setting up our movement assessment. The other thing that follows closely to this is going to be the concept of stability and mobility. And this is an oversimplistic way of thinking of it. And I'm going to bring this back to our treatment in just a few minutes. It's a very simplistic way of thinking. But if you thought in your head before I show you my next slide, if everybody on this webinar thinks for a second and picks a major joint in the body and just try to decide in your mind, does that joint primarily provide stability? So is it a stable joint? Or is that joint designed to move? Is it designed to do things? Now, if you've done that today on this webinar, if you've thought of that in your mind, what I want you to do after you've picked one out is go to the adjacent joint. I don't care. You can move up the chain, move down the chain, and do the exact same thing and see what type of an answer you get. Now, I'll do this for you. And since I said I largely work with hips on a little picture here, I'll use the hip as my example. Hip joints are designed to be mobile. They're triplanar, ball and socket, moves nicely. If I move up the chain regionally, the next region I come to would be my lumbar pelvic region. Lumbar pelvic region is designed to be stable. We should have a nice stable core when we do things. If I move up the next chain, thoracic spine. Now, as a unit, not individual motion segments, but as a unit, thoracic spine is designed to be mobile. It allows us to rotate our trunk in space. Next joint out, scapulothoracic articulation. Our scapula needs to be stable. Next joint out, glenohumeral joint. We're back to a ball and socket joint. Well, that's a mobile joint. Next one out, elbow should be stable. Hinge joints tend to be stable. And then we have our wrist and hand, which is mobile. Or if I drop down from my mobile hip, a knee joint, again, much like our elbow, it should be stable. We drop down to our hind foot. That's a mobile articulation. The body's designed to do this. Now, and that's natural. And I don't think it's by happenstance. There's reasons for this because stable joints in general provide a base or a point of stability from which mobile joints can work off of. But here's what happens. That if you really think about it, if a joint loses the ability to be mobile or poor mobility can force stable segments to become mobile segments. And I'm going to give you the best example I can think of with this. It's one I see largely with golf, but I see it with a lot of different things. Number one injury in golf that I see oftentimes is low back pain. Well, we said low back should be stable. And when I start to examine a lot of these athletes that come in with the patients I look at, and they don't understand why I'm not looking at their back, and I can give an example of one just recently. The person came in with a 3-year history and 3 years of treatment, a professional athlete, for low back pain. When I started examining this individual, this person had 5 degrees of internal rotation bilaterally. 5 degrees. That's almost not even within we could measure. Now, think about what's happening. If I take the mobility out of the hip, particularly if you're in a rotational sport or rotational activity, if I take the mobility away from the hip, guess what's going to happen to my adjacent joint? It's going to become unstable or sloppy. So my hips became stiff, and it could be for lots of reasons. It could be OA. It could be you really have a pathology in the hip. But it's going to force my lumbar pelvic region to be somewhat unstable. And if I work up the spine, the thoracic spine oftentimes becomes stiff. These people, if you keep looking, have scapular winging or scapular instability problems. And secondary to that, we're going to see a mobility problem at the glenohumeral joint. The whole pattern flips. So what we try to do with treatment, when we look at this, is the goal of everything I do is, I guess, first and foremost, identify, which I'm going to talk about next, the problem, but ultimately restore mobility back to the joints that need to be mobile. And if we do that, in many cases, our stable joints flip back and operate the way they should be when we look at this. So I sort of say to people, then why is this even important? And it's important is what I just said, is we need to identify from our assessment piece, are we dealing with a mobility problem or are we dealing with a stability problem? And I realize, again, for all of our viewers today, that's relatively simplistic, but we don't need to make this hard because if you can break it down into 2 buckets, stability problems or a mobility problem, your treatment program's all set up for you. If it's a stability type problem, then we need to emphasize strength, stability, and for me, most of the time, motor control training. On the other hand, if there is a mobility issue, much like the analogy I was just giving you, there's only one more step before I'm treating. I need to decide, is it a capsular restriction or a joint mobility problem, or do I have a problem with tissue extensibility, extracapsular problems? In that case, I'm going to emphasize, or in either case, I should say, I'm emphasizing joint and soft tissue mobility exercises with this. So we need to kind of remember the assessment piece determines my treatment, and the treatment determines the corrective exercise programs or patterns. But you have to understand that while I might spend a little bit extra time in my assessment, it's going to save me a lot of time in my treatment, because by the time I'm done an assessment, I already know exactly what I'm treating or what I need to be looking at. And if I'm on this mobility side and looking at this, I think, and we identified perhaps where the mobility restrictions are, and it's going back to my principles of regional interdependence and that stability mobility model. Once we've identified a mobility restriction, then there's one last step, like I said, in the process. Is the problem capsular that requires me to mobilize, or is it extracapsular that would require me to do soft tissue work? Quite easy. This can be done simple. If I know in my little picture I put up here, and we look to sort of the right side, if my physiologic motion is restricted, I only have to do one more step, and that's joint play or accessory movement testing. I'll do my joint glides to look at arthrokinematics, and there's one of two responses. Actually, technically, there's three responses. My arthrokinematics can be normal, in which I don't have a problem at that joint, but think about it for a second. If my joint play is abnormal, if joint play is restricted, then I know for a fact from an arthrokinematic point, and this is just principles of manual therapy, I've got a capsular problem, and where I'm going to begin my treatment is going to be in joint mobilizations or manipulations if your practice act allows you to do that. And I would correct my capsular mobility problem first and then reassess. If I reassess and my capsular, my joint play, or my arthrokinematics or my joint glides are normal, but I still have a restriction of physiologic movement, then I know my problem has to be extracapsular and a problem with muscle, fascia, tendon, those type of things. And specific to what Kate had us on here today talking about, quite honestly, that's exactly where iStim fits in for me. Anytime that I have a problem with my soft tissue, or what I call a tissue extensibility problem, I come right back to that and we have to restore it. The message I'd like to get out with this, and we use iStim and HawkGrips tools all the time in our treatments. And oftentimes, just so I want to sound like it's too idealistic or academics as I'm talking here, but oftentimes if there's physiologic motion loss, or we've identified that motion restriction, capsular and extracapsular tend to go together. But rules of arthrokinematics are we have to restore capsular mobility before we can do passive angular stretching or work on these extracapsular tissues. So I still would start with my joint mobility, always reevaluate, and then start doing my extracapsular soft tissue things. And I said that's where I fit in with HawkGrips and do things. The important take-home message is you have to correct mobility dysfunctions before progressing to stability training. Or another way I say this oftentimes, never, ever bring a stability exercise to mobility dysfunction. If you have a lack of mobility, and I go back to the analogy I used a little bit ago, if you go back to somebody that has both a mobility and a stability problem, the low back pain perhaps is a stability problem, hips in the case I gave was a mobility problem. If you remember what I said, the last person I had plenty of resources, a professional athlete, and they were doing core training, core stability training for the lumbar spine, had been working on it for 3 years. And quite honestly, this person had a fantastic core stability training program. It's something we could probably write up and publish. But the fact of the matter is there is an underlying mobility problem at the hips. So this individual could do their core stability training for 5 more years. It really wouldn't make a difference, because until we correct that underlying mobility problem, we're always going to have a stability issue, because those hypomobile joints are going to force adjacent joints to become unstable. And that was kind of the message I wanted to bring in here today to talk about, was looking at that and trying to give you a little bit of background of what I look at with mobility and stability, and then sort of play it off there with the mobility side of where does iStim fit into this. And iStim fits in as a big role in this. And the big role for me personally, while I certainly can use it with capsular restrictions as an adjunct to my mobilizations, I use it all the time for soft tissue extensibility problems with that. It's a fantastic tool that helps me correct the problem, reassess, and then move on. If I need stability training, I'll go that way, or motor control training. In many cases, my problem's solved. So I know that's kind of a quick overview, kind of what I do. And the time, I think I went a little longer than Kate gave me, but as you can tell, from the South, I got on a roll, and I didn't slur my words too much with that. But I thought I was going to turn it back over to Kate here and see if there's things she's picked up or questions that people might have, and we can open it up for discussion.
Well, first of all, I love your slideshow. It's funny that you had that Mission Impossible mouse. Yeah. My husband and I, we have a newborn, so we don't get out as much as we used to. So we've been rewatching series, and Mission Impossible is actually what we're on right now. So I was very appreciative of that little mouse.
There you go. We're solving the problem. So it's not Mission Impossible. It's actually Mission Possible if we just put various rules in play.
Yeah, Mission Possible if educated.
There you go. Perfect. Perfect way of saying it.
One thing I really like is that if you don't consider dynamic movements, I mean, we all look at how people move, or there's lots of memes out there where wow, that lady has an anterior pelvic tilt, or, we have little fancy things that we kind of point out when we see it, when we see our patients come in. But if we don't actually consider how somebody's moving when they're in motion, not just their motion, then we're really just beating a dead horse. We're not going to go anywhere.
That gets back to the way, and it's no fault of clinicians, I think, because where this comes from, I don't think you were wrong when we start our careers and go down this road. It's how we were trained. We were all trained to do, as I sort of said at the start, isolated joint function. It hurts here, so this must be the problem. So I'm going to focus all my attention to this. But I'll use another example, and again, this is my opinion that I'm saying to you. So I could give you some facts to back up my numbers. I can't tell you the why, but if we just look at either low back with recurrence rates, or even now in athletics with, let's take anterior cruciate ligament tears and reconstructions, it's fascinating to me that the recurrence rate to that is as high as 40%. That within 2 years, a person will either re-rupture the repair or rupture the contralateral side at the knee. And I'd sit there and think about it is, why does that happen? And the only thing I can surmise by this and put it together is quite possibly whoever's working with them probably did, I'll give you the benefit of the doubt, did a great job getting these people back to play, getting these people rehabbing that knee joint, getting them back to where they needed to be. But unless you looked at the total picture, maybe we missed the cause in the first place. Unless you took care of the cause and we put these people back on the assembly line or back out to work or back out to play, problems are going to recur. It's just a matter of time that it happens because you never got to the real cause of the problem.
Yep. And I mean, pain, as you said, pain can be kind of an identifier, but pain sometimes is the victim, not the criminal. So you have to, like I said in last week, you have to figure out what is actually causing that. I mean, the top risks for injury, core weakness, muscle imbalances, musculoskeletal abnormalities, and poor neuromuscular control. But some of the special tests that you're right, that we learn when we graduate and that we're excited to use on our patients may not actually give us the full picture, which is part of the issue.
And I don't want people to walk away thinking that I don't think pain's important. Pain to me is just an indicator that something's wrong with the biological system. But here's where I've put in the big picture and why exercise doesn't work. You go down this road. Pain can be present, as you just said, for a lot of reasons. Injury can cause pain. Pain can cause injury. But here's the biggest thing we know about pain and sort of the pain models. Pain will change the way you move. Pain changes motor control. So if I don't get to the cause and try to correct it, and try to just maybe jump ahead, like these people that do core training when there's other things, potential other causes with this. If I do that, the problem is that pain will still cause inhibition or facilitation in other segments, but I'm never going to get the corrective response I want, because if pain's present, motor control's altered, and we're going to have, as I said, poor patterns of movement or compensations taking place. And all we're end up doing is reinforcing a bad movement pattern or compensation. Figure out why there's pain, figure out the cause, address that, and then go back and see if we need to do motor control training or other things with that. I'm not saying people are always just weak. Certainly if there's long-term immobilization, we might have to work on muscles or things. But to me, the precursor to all this is respect the pain, address it, but ultimately get to the cause of the problem.
Yep. We have some good questions coming in, actually. We're going to start this Q&A section. And for those of you guys who are still on with us, thank you very much. We're just going to stay on to answer your questions as long as we need. Mike's been gracious enough to give us some time today. First, going back to the instruments, we both use them, facilitation, inhibition for addressing soft tissue dysfunction. Do you have a favorite tool?
Yeah. Well, I'm going to, you saw me sort of hesitate a little bit this, and I'll tell you why what my tool is. And I actually, I'm going to give you three. I have, and I'll put them in a hierarchy, but I'll tell you why. I'll qualify why. I do a lot around the hip. And so I said, see, a large part of my practice is hip. So as such, within the HawkGrips family, I use the handlebar a whole lot more, the big tool. For that, because I can cover a larger surface area. I like the way it's sort of been redesigned over the last few years. That gives me feedback to that with the handles the way they are. So I would have to say, because of the hip, or just because of the region I deal with, that would be one. The other tool that I was going to lean to at the start to come back to is if I think you do a really, really good assessment, and I use the tools for assessment as well. And I've done, and this is kind of a little funny story for the viewers today, but the fact that they're on a HawkRips webinar, they probably use tools and have experience with it. But I can remember the first time I met Frank Osborne and Sean McNeil, and they were talking to me about stainless tools and how they resonate, and you can feel things like a stethoscope and all that. And I kind of called them out on it. And I said, I don't buy that for a minute. And they sent me a set of tools to play with for research. And it was amazing to me because one of the tools I use around the hip all the time is a diagnostic ultrasound. So what I did is when the next several patients came in, I used the diagnostic ultrasound, or I had my colleague do the same thing, and identified where the soft tissue problem was. So we knew exactly what it looked like because I can see all the way down to bone with my ultrasound. And then we said, okay, let's take the tool, and can you, without knowing what the ultrasound results were, could you find the exact same spot with the tool as it resonates over the abnormal tissue? And the reality of it is, it absolutely could. We matched up 100%. We played, it didn't matter what role we took. If somebody else was doing the ultrasound or I was doing the ultrasound, the opposite person would do the tool. We always ended up in the exact same spot. So my second tool, long way to get to it, is I like the tongue depressor, like one as well, provided you can find exact lesions. And it works well around irregular surfaces, but even in a big muscle, for me personally, if I can find where the problem is, and I want to get in there and do some deep work, I like the tongue blade one because I can get there and start to work on either the mechanotransduction or breaking some abnormal links with it. So I kind of like that one. And then having said it, I'll tell you the one I use all the time and why. I use the multi-tool.
The HT Pro?
Yep, I use it because here's why. I travel a lot with the athletes and do things, and it's something I can easily throw in my carry bag. Sometimes it does get through TSA. Sometimes it doesn't. In a suitcase, they do look at it if it's in my bag and I forget to take it out and I have to explain to them what it is. But I've never had it taken away, thank goodness.
Going international, I brought it on my honeymoon, the HG Pro.
There's probably a story in that, but that's another webinar.
Yeah, but yeah, it's great for travel, especially because it's light, comes with a case, it has all treatment edges. I'll ask Justine to put a link on here so y'all can see it if there are people on here that don't know what it is.
Yeah, it's a great tool. You're right. I can mimic everything in a set with that one tool, with the exception, I don't have the same thing I get with the handlebar, but sometimes I'll throw the big handlebar piece in and then take my multi-tool with it. So with the Pro. So to me, if somebody was even thinking about getting into tools, that's a great entry-level tool. But I'll warn you right now, I know it'll happen. You'll start using the tool and you'll realize I want the others for the various reasons that they use. But I think it's a great tool to get into and use initially.
Awesome. We have another question. We have a lot of questions, actually. We may not get to them all, so I'm going to kind of run through them. So what would make you choose to use iStem? And this is a loaded question because patient-centered care, you kind of take each patient for who they are and what they present with. But why would you use iStem versus traditional soft tissue mobilization on an average day? Like, what is your indicator that says, hey, you know what, I'm going to pull out my HG Pro instead of my thumb? What is your reasoning quick reasoning?
I'll give you a couple reasons. And I can tell you, you are correct. So as we answer some of these questions and go through it, I will tell you that is a true statement that obviously every patient's independent and presents differently as far as what I may or may not do. But actually, this one's going to be a little bit more consensus with this. If you were 100% sure you knew what the problem was and where the problem was located, I guess you could argue whether or not you want to use a tool or not. I use the tool first and foremost as a part of my assessment piece. If I go back to my stability mobility model, I know there's a problem with mobility. I've excluded my capsular tissue perhaps, so I know I've got a tissue extensibility problem or a problem with muscle, tendon, fascia, or something along those lines. I can identify with my tool, and again, everybody's different, and I may not have good hands-on skills, but I can find the tissue restriction or the problem a lot easier with the tool in my hand than I can with my hands. Now, 5-6 years ago, I wouldn't have agreed with that. I would have said, no, my hands are good. I've done this a long time. I can find it. But I've been convinced, largely because of what I did with the ultrasound, that I can find dysfunction a whole lot quicker with the tool. And then quite honestly, and as I get older, I can do a lot of things with my hand. But if and remember, a tool, particularly a stainless steel tool that will resonate and give you feedback, a tool works just like a stethoscope to a certain extent. I could put my ear to somebody's, cubital fossa at the elbow and try to listen for a pulse, but it's a whole lot easier to use a stethoscope and hear the same thing. Same thing with the tools. I could probably use my fingers much like I would have done with Cyriac's cross-friction massage years ago. But if I use a tool, I preserve the integrity of my fingers, and I still get the feedback to my fingers. So I'm not giving anything up by using the tool. If anything, the tool enhances and provides feedback to my hands. So why not make it easy on yourself? And I think we can be more, my personal opinion, is I can be more efficient with the tool than I could with my fingers. So joint preservation and perhaps efficiency, and which is both secondary to the assessment piece, is why I use the tools. So for most of my soft tissue restrictions, and I won't say always, but I'm probably, it's higher than 90%, 95%, I'm going to be using a tool with that mobility restriction that I found.
I like it. And somebody actually chimed in the room, the difference between, and this can be another webinar in itself as well, the difference between plastic and stainless steel, why one is better than the other. And without, with remaining PC to different maybe companies out there that offer either or, personally, it just has to do with the qualities of stainless steel itself. Plastic does not have the quality that stainless steel does. The component, what it's made of, does not present itself with the ability to give that resonance, that same resonance. And I think that's one of the main reasons why surgical grade stainless steel is preferred as a clinical instrument. Correct?
And I'll just say, Kate, I'm kind of a nerd on this stuff. That I'm, having been in professional sports most of my career, I'm a skeptic when somebody brings me something new and tries to tell me this is the best thing that you can use. And so I will always, I investigate stuff all the time. And when Sean and Frank came to me and said about these tools, I was a skeptic, but I went and proved it to myself. And then that question came up to me. Why do I want to pay for stainless steel when I could probably go buy on Amazon a cheap plastic tool? And here's what I tell people, quite honestly. If you know what the plastics will not resonate, they won't resonate the same as stainless, and it won't work in that regard. So plastics don't work as far as assessment. They won't. But if your whole goal is treatment, you could probably use it for treatment. If you knew all you want to do is break some cross links and do some tissue teasing, that's fine. But another problem I found with the plastics is they break quite easily. And when I say break, it's not that they snap in half and you have a problem with that, but if they get dropped and you do things in the clinic, they get little pits in them and scratches, and those are a harbor for bacteria. So if you're using plastic, I remind people to always make sure you're sterilizing the tools. When I went to the stainless side, a lot of people make stainless tools, and I even learned this from HawkTalk. You said medical grade. I think I talked to one of the engineers one time, and I actually took this to our engineering department at Vanderbilt and asked them, and they validated all this for me. Not that I didn't believe them, I just wanted to know about metallurgy 101. And these guys explained to me why the stainless resonates and other, like aluminum won't, a metal won't, a stamped metal. But here's the one I started laughing at. They told me, well, it has to be stainless 316, I think is the number.
There's different grades of stainless steel.
Different grades. And I'm thinking 316, what is 316? And finally the engineers told me, well, that's marine grade or surgical grade. I said, oh, now I know, it won't rust. And the more important thing is, a lot of people make stainless, but the other piece you should look at when you're looking at a tool and sizing up tools is the leading edge. There are some that are out there, but the leading edge is not very pointed, and your convex or whether the bevel, when it comes down to, is not, it's more rounded or sort of a double beveled edge versus a nice, like a chisel, if you want to think of it that way. So I'd look really close at how these tools have been machined. And unfortunately for the end user, the amount of work that goes into the cost of stainless or medical grade stainless, and or the amount of time that goes into milling to get a great treatment edge does add to the cost of tools, but it also adds to the usefulness of the tools with regards to the assessment side of things, and I think the efficiency of treatment. You could have a stainless steel tool that has dulled edges, and you're not going to get a lot of feedback from it. That's one of the things I like about the HawkTalk tools. It's not only that they're dealing with good quality stainless or medical grade stainless, they've been milled to a nice fine edge that gives tremendous feedback to my hands.
We do more of a handcrafted process than the average facility, which, and I do see and hear a lot of people that say, oh, wow, how much I can use a spoon. Okay, yeah, in some ways you can break up crosslinks with a spoon, but I mean it's a clinical investment to your career. Think of it that way. I mean, you like you said before, doctors buy stethoscopes and people invest in all other sorts of equipment. This is just an extension of our hands and a tool, pun, but a tool that we're going to use to help treat these individuals. Right. Last question. Okay. It has to do with functional movement screens. Now, I know that you have your own programming, so this is kind of a try to be unbiased, but okay. In your opinion, what are the great movement screens? Like, what are the great systems that you should be learning? Or why don't, this is a great chance for you in the last few minutes that we have now to talk about your education. I can personally attest that I took one of the functional movement courses. The Scrape Tape has a little bit of that in it, but yep. It was phenomenal. It was phenomenal. I took it home the next day and used it with some patients. So if you could just kind of go into maybe what you're working on right now, what's coming up. We have posted in the website, rehabeducation.com. So everybody here can look at that as well.
Sure. Yeah, that's an easy one. And I'll just give the 1 minute, 2 minute spiel about where it comes from. Is that I've been looking at movement for probably going on 25 to 30 years. And if those on the webinar, dabble in movement and look at movement, and this will date me a little bit on it, but one of my students a long time ago, we won't just give ages on it, but was a young man named Gray Cook. And Gray Cook, as many of you know, developed the functional movement screen. And Gray worked in the clinic with me, and we did things. Here's the problem with the functional movement screen. It's not a problem. The functional movement screen is a great tool. It's a screen to appraise globally what movement patterns are, but it's more like a physical of looking at normal health, and we can go up and down. And where we went with this, or where it evolved, was this. For those that use the functional movement screen, is one of the fundamental rules of that screen is that if any movement, any of the 7 movements that a person looked at, causes pain or reproduces pain, the whole test is negated, and they need to be referred to a healthcare professional. Well, at that point in time, this is back in the early 90s, Gray and I talked and doing things and said, well, if we think movement's important and we're now referring people that we think have movement problems to clinicians, what type of assessment are they going to use in the clinic? And so in I think it's about 1994, Gray and I came up with our first iteration of the SFMA, the Selective Functional Movement Assessment. And we started teaching it, and for those that could have seen us back in the mid-90s, it doesn't look anything like it does today. And other people have gotten involved. Dr. Greg Rose with Titleist Performance Institute works with this, and we all have helped develop this over the years and perfect it into a clinical tool. And the biggest thing we look at with the SFMA, and that's the tool I use, and that's what I teach. So that the link that's up there is going to be one of our information sort of things. I think we can go to it's just our company this slide here, is we teach that and slot it into where it needs to be. And there's 2 or 3 companies that teaches SFMA right now. We all work very close together. We're friends. We all do things, and it's all the same. Whoever you go to, it's going to be the same material. We use the same slides. We use the same textbook, but that's the movement assessment. But here's the question we always got. So that's of the things I do and teach. I use the SFMA as my approach to, and it's so real quick, I have a patient come in, we do a history and observe. I might do my upper or lower quarter screen. I do my SFMA or movement assessment. And based on that, I sort of go the rest of the way with sort of a hypothesis-driven approach to the rest of my assessment. And that's going to be looking at various, the tools we learned, the special tests we learned to confirm my diagnosis. But one of the things I found along the way was people kept asking me, hey, this is a great tool. The students love it because I have it fully integrated into the university. But what I kept hearing was, and it might be a little bit aggressive in the statement, largely my students, is I think this tool works great for assessment, or I don't feel I'm going to get stumped assessing anything related to movement. But here's the big one that's disheartening. I'm not sure how to treat it, or I have this problem. What's the best way to treat it? And largely, we sort of within SFMA have a treatment philosophy of what we call the 3 R's. And 3 R's are resets, reinforce, reload. If there's a mobility problem, we reset it. Let's fix the mobility problem. If we do something for mobility, or we were doing some exercises, we always want to reinforce it. with our home exercises. It could be stretching, it could be taping, and reloading is reloading software. That's motor control. Hence the name of this other course, Scrape, Tape, and Move. We use our scraping as a form of our mobility resets. We use taping as a reinforcement to what we're trying to accomplish, and our reloads is the move. That's how we teach movement things. So we developed a second course, and it's a 2-day course now. And largely the first day we go through overview of movement assessment. If a person hasn't had SFMA, they still are going to be fine because we teach our base screen the first morning, much like Kate was attesting to, has seen how we teach it. Then we get into all the principles of iSTEM. We practice with iSTEM. We talk about the myths and or then the application of tape, both dynamic tape and or kinesiology tape and dynamic biomechanical taping. And then we teach a guideline of exercise prescription of how we would put it together and progress our exercise. And then from there, we just start taking body parts. We do cervical spine, we do thoracic spine, we do the hip, we look at the knee and ankle. We go through all these areas and we treat them. We list out, here are the common mobility restrictions we find. We talk about differential diagnosis. We apply the iSTEM, we apply the taping, we apply the exercise principles. And when it's all said and done, working closely with Hawk Grips, we actually then have a written test that people actually will get a test at our course. Those are pretty easy because a lot of people can pass written tests. Probably the more important one is we also do an oral and a practical component in our tests. But more importantly, when people leave, they are level 1 certified through Hawk Grips with iSTEM, and we give them a kinesiology biomechanical taping certification as well. But they've already demonstrated to us that they can use these tools appropriately, and they've demonstrated they know how to apply tape in the right situation and exercise prescription. So back to what you were asking me, what we do, I largely teach in 2 classes, but we do our movement assessment course with a limited amount of treatment. And then we have our Scrape and Move certification course where we largely get into, here's all the different mobility and stability type problems we have and go through all the corrections. Not meaning that my way is the best way. I love discussion in classes. People show us theirs, we show you theirs, but we will show you our favorite ones that you'll see us doing in the clinic every day. It just is the ones that works for us. Doesn't mean it's the be-all, end-all list, and we'll give you a comprehensive manual with all that in it that you can take home Monday and you would have tools to use when your next patient comes in.
That's awesome. First off, I want to thank you. And we still have quite a large group of the people that showed up for the entire webinar still listening. So thank you guys who are still on board with us.
For everybody.
I know, I'm so excited that you guys came. I mean, I was just sitting here thrilled looking at this stuff. I love functional movement screens, and I love how how do I word this? I like how the APTA, especially being a member, and I work with the CPTA, how they're going to finally kind of incorporate this as, I mean, rehabilitation science, it evolves just like any other science. So it's not, like you said, it's not like people are doing anything wrong, but this is just hey, we find out this works better, let's use this. But anyways, thank you for everybody who came and are still listening. We actually have a special gift for everybody that joined us today. So keep an eye out on your email in regards to tools and whatnot. So please check that out.
Do we get gifts or anything?
You do.
I'm joking with you. I'm joking, Kate.
You do, but you need to send me your home address so I can stalk you. So.
Well, the reason Kate says that, she knows that this is the start of music festival week here in Nashville. So all the country music artists are in town, and I'm leaving right from this webinar to head to the arena downtown because we have the CMT television awards show tonight. So I'm heading off to an award show.
With everybody in Nashville, which includes all the people we all want to be friends with.
I'm just old and been here a long time.
I think it's awesome. But hey, if you get the chance to see my cousin Haley and Michaels, that would be really
cool. Up this week.
Yeah, they said they're going to be on one of the stages. So if you see them, maybe I'll ask them to shout you out, huh? That'd be kind of cool.
You are something.
Anyways, guys, thank you so much. This will be available for replay if anybody missed anything in the next couple of hours and on our website under HawkTalk Live. Thank you guys all for coming. Mike, thank you. I know you have a busy week and fun week. I'm so glad you came on.
It's going to be a busy week, but I enjoy this and I look forward to coming back in the future.
Awesome. Thanks again, Mike. See you guys.
Thanks. Bye.